So I feel like we can't talk about sedative pharmacology without first understanding how GABA receptors work. So these are channel receptors, and when GABA binds these channels, they change the shape to allow ions to pass through, mostly chloride ions. It's classified as an inhibitory transmitter, and the primary target for several neuroactive drugs like barbiturates and steroids, general anesthetics, alcohol, benzodiazepines. So I feel like pharmacology can get pretty complex. And whenever I'm trying to either learn more about a certain area of pharmacology or if I'm trying to teach, I really love to turn to these short videos that help explain it with animation.
Welcome to 2-Minute Neuroscience, where I explain neuroscience topics in 2 minutes or less. In this installment, I will discuss benzodiazepines. Benzodiazepines are a class of drugs named for their chemical structure that are commonly used to treat anxiety disorders and sleep-related disorders. They include well-known drugs like Valium, Xanax, and Klonopin. There are dozens of drugs in the benzodiazepine class, but the mechanism by which they all exert their effects is thought to be similar. The sedating and anxiety-reducing effects of benzodiazepines are believed to be attributable to the drug's actions at receptors for the neurotransmitter gamma-aminobutyric acid, or GABA. In particular, benzodiazepines act at a subtype of GABA receptors called the GABA-A receptor. GABA-A receptors that also bind benzodiazepines are sometimes called benzodiazepine receptors. When benzodiazepines bind or attach to the GABA receptor, they bind at a location separate from where GABA itself binds, and exert an influence over GABA binding. This type of action is called an allosteric effect, and in the case of benzodiazepines, it results in an increased action at the GABA receptor. There is not complete consensus on exactly how benzodiazepine binding affects activity at the GABA receptor, but there is evidence to suggest that it increases the likelihood that GABA binding will activate the receptor and/or increases the effect that GABA has when it binds to the receptor. That effect is to open an ion channel and allow the passage of negatively charged chloride ions into the neuron. This influx of negatively charged ions pushes the membrane potential further from zero, or hyperpolarizes it, and makes it less likely the neuron will fire an action potential. This type of neural inhibition is the basis for the effects of benzodiazepines, for by inhibiting the activity of neurons that make up networks involved with anxiety and arousal, the drugs are able to produce calming effects.
So what works on GABA? So minor tranquilizers, benzodiazepines, anticonvulsants like phenobarbital, adult beverages, volatile and injectable anesthetics. So the more medications that you administer that work on GABA, the more these are going to work synergistically, and the more profound the effects will be. Hopefully none of our animals are drunk when they come in. But think about medications like, say you have an animal who comes in who's epileptic, so he's on Keppra, and then we pre-med him with midazolam, then we induce him with propofol. All of these medications are all triggering these GABA receptors and going to have a much more profound effect than if we gave just one of these medications. So we've got a few different classes of these drugs. Our most popular are benzos. We also have alpha-2 agonists, phenothiazine derivatives, dissociative anesthetics, which is sort of an outlier, but I really want to talk about ketamine. I feel like I can't talk about sedative pharmacology without talking about ketamine. And then we're going to talk about some adjunct oral sedatives. So the benzos. So their mechanism of action, so they work on GABA receptors in the CNS to promote depression, which in turn we see sedation, hopefully. We'll talk about that. Anxiolysis, so these are true anxiolytics, diazepam and midazolam. They are muscle relaxers. They're used as anticonvulsants. They have, like I said, mild to moderate MAC reduction, and they are reliably reversed with flumazenil if needed. However, benzos can be unreliable as a sedative alone. They are, however, reliable in the very young, very old, and very sick. I'm going to repeat that because it is so important, the very young, the very old, and the very sick. If you administer a benzodiazepine to a patient not in this category, you have no idea what you're going to get. Think about that fractious pit bull that comes in, all upregulated. If you give that dog midazolam IM, you could have what's called a paradoxical excitation response, where it just makes him more upregulated, and then you are going to need a higher dose of drugs. Has anyone ever witnessed that with midazolam? Yeah, so many yeses. Okay. So cardiovascular, we have minimal depression of heart rate, contractility, and cardiac output. That's why we like these drugs. Perioperatively, minimal depression of ventilation and oxygen delivery. Metabolism, however, they are slowly cleared. So we have to be careful with repeat or high dosing, and we have to be cautious in patients with any type of hepatic disease. So let's talk about diazepam. So this drug is poorly water soluble. So what do I mean by that? Well, its carrier is propylene glycol and ethanol, which has a very high pH, and that's what makes it sting when you inject it. It also, because of this carrier, it causes erratic absorption because of this pH. It's hyperosmotic, so it can cause hemolysis. It is at certain doses renal toxic. You actually have to be careful giving diazepam in patients with renal disease. It's light sensitive, so photodegradation. So this drug binds with plastic if exposed to light. Does anyone know how long you can keep diazepam in a syringe for before you have to discard it? Yes?
24 hours or less.
3 hours. 3 hours before it starts binding with the plastic. So if you ever have a patient, when I was at AMC, when we would have the status epileptic patients and they would need to be put on a diazepam serai, we would actually just have to calculate for 3 hours and then switch out the entire line. So it's important for us in shelter medicine to know this, because a lot of times with our high volume spay neuters, how often are you drawing up all the drugs at the beginning of the day? All the time, right? So it's really helpful if you just do not draw up the diazepam and just do it right before, or just draw up the first half of the days first and then the second half. The half-life of diazepam is 3.2 hours. That's kind of a long time. When we're doing a spay, that takes like 20 minutes. So that's always something to keep into consideration for post-op dysphoria. It's going to precipitate if combined with anything other than ketamine. Does anyone know why? No one does. Trick question. For whatever reason, it just can be combined with ketamine, but nothing else. So that's the only drug that you can combine diazepam with. And our dose in dogs and cats is 0.1 to 0.5 mg per kg IV only. Any questions about diazepam? Okay, so midazolam. So midazolam has a low pH, it's highly water soluble, so it is rapidly absorbed via IM injection, which is why we can give it IM and mix it with other medications. Again, same deal as diazepam, light sensitive, can keep in that syringe for 3 hours, and always cover your benzos. I feel like I walk through surgery every day saying, cover your benzos, cover your benzos. Just take that vet wrap and wrap it around it when you draw it up, and that's gonna help it not go through the photodegradation. Bioavailability. So 90% peak plasma concentration happens in 15 minutes, which is just a little bit slower than diazepam, and the half-life is 1 hour. So that's kind of huge compared to diazepam. And this is why, for me, perioperatively, I always choose midazolam over diazepam. The only time I'm really reaching for diazepam is if I have an actively seizing patient, because it's going to cross the blood-brain barrier quicker. Like I said, it can cause excitation, especially when it's administered IM, and it's most commonly combined with ketamine or other opiates to potentiate sedation. Same dose as diazepam. Contraindications. So there are very few physiologic contraindications to benzos, which is why they're so popular and why we use them all the time. However, we do want to avoid diazepam with all of those concerns for the carriers. So patients with liver dysfunction, severe anemia because of the hemolysis, and for any short procedures because they could potentially have post-op dysphoria. And flumazenol reliably reverses it, right? So we can always give flumazenol, but the half-life of flumazenol is 30 to 45 minutes. So we could have to then repeat the dose. It can always make behavioral management worse, so that's why we want to kind of avoid it in these tough behavior cases as well, both benzos. Okay, alpha 2.